problem. So
Will do, and I've started recording.
welcome everybody to our support group meeting. We're very pleased to have a speaker today, and you're with UF Health, but you're down in Gainesville, correct?
Yes, ma'am.
Great. So I'm going to turn it over to Dr. Chen, and then she's going to do a presentation for us, and she has agreed to stay around and do some Q&A after her presentation. So I think that's great, and thank you very much for actually you all reached out to me, which I thought was
Turn off the Bluetooth, I think. I don't know.
Oh, somebody's
I don't
got
know how it's
background.
So, okay to start, Diane? Okay, great. So nice to meet you all virtually. My name is Si Chen, and I'm one of the neurotologists at University of Florida in Gainesville. So this is a very brief presentation, hopefully to give you a bit more information, and feel free to ask questions. I'm happy to answer any questions for you guys. Obviously, this is a good support group. And just thank you, Diane, and thank you, Melissa, for organizing this and inviting me to the talk. So I have no financial disclosures, but just one thing is that this presentation does not represent any medical advice. So let me know if you have individual questions, everything sort of has to be based on your individual cases. The goal today is to give you a little bit of review of the relevant anatomy and testing. Obviously the goal is to allow you to understand some of the anatomy, and you've probably been through so many tests that allow you to understand some of those tests to empower you to take control of your own diagnosis. And also we would just discuss briefly the hearing of balance and facial nerve outcomes in terms of the different treatments for acoustic neuroma. The relevant anatomy is just very intricate. This is a diagram of an ear. You can see this is the outside of the ear that you can all see, touch, and feel. This is the ear canal. That sound travels through the ear canal, hits the eardrum, moves the three little bones in the middle ear to go to the inner ear, which sends the signal to the brain via the hearing and balance nerve. You can see this is the hearing organ, this is the balance organ. And those nerves travel in the same tunnel called the internal auditory canal, which contains three important nerves: the hearing nerve, the balance nerve, and the facial nerve. So you see that they're all intimately related together. And sort of in the same tunnel going to the brain. And acoustic neuroma, I'm sure you all know, is also known as a vestibular schwannoma. It's actually a benign growth of cells covering the balance nerve. You see its relationship with the facial nerve and the hearing nerve. Thus, the anatomy is important to understand all three of those outcomes in the treatment options that we have available for acoustic neuroma patients. Most of you probably know this better than I do, is that the symptoms of diagnosis, most patients have a little bit of hearing loss. Tinnitus is significant. Balance disturbance.
No, you're just going to stay in the car.
Was there a question? The balance disturbance can range from a variety of, slight dizziness, a little cumbersome, to severe vertigo. And hyperacusis is what we call sound sensitivity. It's commonly seen with acoustic neuroma patients that the loud sounds are very bothersome. Facial numbness, weakness, and swallowing speech issues are less common. However, it does happen. Usually those are with very large tumors, and double vision can also happen, not nearly as common as the other symptoms. I bring this up is to show you that your variety of symptoms you can relate to other patients, but ultimately the severity of the symptoms to you is what matters the most. And when you're discussing treatment options, it's important to know the severity of your balance disturbance and what the hearing loss levels are and what your facial function is at baseline. So those are things to consider. In terms of understanding hearing, this is a hearing test or audiogram of a patient with a right acoustic neuroma. I don't know if you've had somebody explain this to you, but hopefully I can try to help you with that. In terms of the hearing, on the left-hand side, you see the loudness scale. 0 to 120 decibels is how loud the sound has to be in order for you to hear. 0 is the best, 120 is the worst. So the lower in the box, the worse you're hearing. Up to 25 is normal. So within the blue box is normal hearing. And we actually speak between the frequencies up top are the pitches of your sound, the left-hand side, piano keys, right-hand side, left-hand side, boom, 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 right-hand side, boom, boom, boom. We actually speak between 500 and 3,000. So within the yellow box is your speech frequency. And for this patient, the circles represent the hearing across the different frequencies on the right-hand side. You see I marked as an orange circles. And the X's are the hearing frequencies on the left-hand side. So this patient has remarkably good hearing across the frequencies in the low frequency, a little bit hearing loss in the high frequencies, and it's a little bit asymmetric. So right side is slightly worse than the left-hand side. Because of this hearing test, we ordered an MRI and he was diagnosed with an acoustic neuroma. The important thing is that, with enough sound, he understood 100% of the words on the right-hand side and 100% of the words on the left-hand side. So really, he wasn't really noticing any differences except a little bit of hearing asymmetry. So that's a very mild symptom. To put it into perspective, I put the audiogram of familiar sounds for you on the right-hand side. Normal conversation is about 40, 45. So we normally speak in this range. So he's doing perfectly fine with conversation. And with louder sounds like, lawn mower, that's about 100 decibels. So down here is when you need the sound levels of a lawnmower. And the jet engine of a plane is all the way down at the bottom. So that is sort of gives you a sense of what kind of sound levels there are necessary for the hearing purposes. In comparison, I have two patients who have left acoustic neuromas. This is a important point to convey to you that both of them have left acoustic neuroma with left hearing loss. This patient has hearing on the right-hand side slightly better, slightly worse than this patient. You see the hearing levels about the same, 50, 60 across the board on average. However, the patient on the left-hand side, the speech recognition is 68% versus patient on this side that the speech recognition is only 0%, meaning that even though the sound detection level is about the same, no matter how loud you make the sound or the speech to this patient, instead of hearing garble, 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 they hear garble, garble, garble. It's very loud but not clear. So there is a distinction in terms of hearing levels, and this is what we call serviceable hearing. So if you read about the literature or hear physicians talk about serviceable hearing, when the word recognition drops below 50, this is what we call not serviceable, meaning even if I gave you a hearing aid, the hearing is not very usable because you can no longer understand the speech. So that's what that hearing test means. Hopefully you've had your hearing test and this helps you understand some of your hearing tests. In terms of balance function, some patients may experience vertigo as a sudden onset vertigo. A lot of patients actually has an over time slow onset of imbalance. And this is because we know that the inner ear or the nerve can be weakened from the balance, from the acoustic neuroma. However, over time, the brain does compensate for the nerve weakness from the acoustic neuroma. It's very important that in the setting of an acoustic neuroma, patients can have headache or migraine in the setting of an acoustic neuroma. That is sort of, you can have both of those diagnoses. It's very important to control your headache and migraine no matter what treatment option you choose for acoustic neuroma specifically. In terms of facial nerve function, it's a common misconcept that the movement and sensation of the nerve is the same. It's actually two different nerves. So when we talk about facial movement, it's controlled by the facial nerve, which is sitting right next to the acoustic neuroma. And when your physicians talk about the House-Brackman scale, which is a very common grading scale for the movement of the face, it goes from left-hand side to right-hand side. Grade 1 is normal. Grade 6 is a complete paralysis. So that gives you a sense of how severe those facial nerve functions are. And the facial sensation like numbness, tingling, some patients in tumors may have a little bit of abnormal sensation. That's actually provided by a completely separate nerve called trigeminal nerve. So This is just to give you a background in terms of what you may be thinking about in terms of your symptoms now and symptoms with treatment and moving forward. Any questions so far? I don't hear any questions. I'm going to continue, okay? So size also matters. So hopefully you've may have seen your MRI. When you're in the MRI, you may remember that you're laying flat on the table. This is an example of an MRI of a patient with a right-sided acoustic neuroma. You're laying on the MRI. This is the back of the brain. This is the front where the nose and the two eyes are. In the MRI images, is actually flipped. So this is the right side and this is the left side. So everything is flipped on your MRI. In the internal auditory canal, which contains the nerves and the tumor, sits at the bottom of the brain between the brain and the ear. So this is a representation of a patient who has a right-sided acoustic neuroma that's relatively small. It's contained mostly within the internal auditory canal. So you often hear the word intrameatal, which means it's a small tumor contained within the canal. You can see the anatomy, it's related to hearing balance, is also touching the brain. So the size of it matters because you can have a little bit larger tumor and, medium size that's touching the brain stem. And when it's relatively large, this patient actually is an NF2 patient with 2 tumors on both sides. And this is a relatively large tumor compressing the brain stem, causing what we call hydrocephalus, too much fluid in the brain. So the reason I mentioned the size is depending on the size of the tumor, the treatment options vary. Obviously, you can see for this patient, because the patient on the right-hand side, because it's already compressing the brainstem and causing hydrocephalus, that you are pretty much essentially looking at treatment option to intervene because the brain does not like too much pressure and does not like too much fluid. So this is sort of 2 ends of the spectrum of the acoustic neuroma, but just to give you an idea that size plays an important role in terms of treatment outcomes. When you read online, there are 3 main treatment options: observation, radiosurgery, and microsurgery. So we'll do a quick overview. When, with no matter what treatment options you choose, the first and obviously the most important is to alleviate some debilitating vertigo, nausea, headache, and hydrocephalus. 40 years ago, those were the only goals, but now with the improving treatment options and modalities, we know the primary goal nowadays actually is provide the best hearing, facial nerve, and balance outcomes for all the patients as much as possible. So we do take your quality of life into consideration when we think of the treatment options. And when we talk about observation, it doesn't mean don't do anything. We actually prefer to call it watchful waiting. So usually the MRIs are repeated on a regular basis. The hearing tests are repeated on a regular basis. And the good news is that most acoustic neuromas do not grow. Only less than 1/3 of those patients who were watched over time will require some sort of treatment in 4 years down the road. So, and dizziness as a presenting symptom can be useful for us because that is very uncomfortable. We do take that into consideration, and a few literature have published to say that dizziness at presentation may sometimes correlate a tendency to grow down the road. This is not 100% across the board. Most of the time, a smaller tumor is correlated with better hearing, and hearing at diagnosis, usually the better your hearing is, the better the hearing will be after a period of observation. And some of my patients call sometimes when the hearing suddenly drops, they're very scared that the tumor growing. And the one thing we do like to emphasize is that sometimes a tumor does not grow at all, then hearing may deteriorate. So that we know can happen with acoustic neuroma, but as long as your hearing is stable, the tumor is stable, you can observe that with a serial MRI. But when your hearing does deteriorate, when your hearing does drop, it is advisable to call your ENT or your neurosurgeon to say, my hearing has changed. Normally what we do is to repeat the hearing test, get a new MRI, and see what's going on. Over time, the dizziness does become better, and the facial function remains relatively stable. in patients who have tumors who were observed. Usually those tumors are not growing rapidly to cause any significant trouble for the facial function. Radiosurgery is the second treatment option. You can probably hear about what we call stereotactic radiation. It refers to both gamma knife and cyber knife. Those are two modalities you might hear the physicians talk about. It really delivers a very targeted radiation to the tumor, and unlike all the other radiation for breast cancer or even head and neck cancer, it's a relatively small dose, and it avoids radiation to surrounding tissues. Obviously, the most important tissue will be the brain surrounding the tumor. With radiosurgery, we do try as much as we can to reduce the radiation to the hearing balance and facial nerve. However, you can see that, hopefully from the relevant anatomy and MRI images I've shown you, it is very hard to completely avoid radiation to all those three nerves. Tumor control is very good with radiosurgery. It's about 98%, meaning no tumor growth. It's important to understand that the radiation does not kill or remove the tumor. So you're not looking at completely getting rid of a tumor, but hopefully preventing the tumor from growing. Hearing, about 50% of patients can maintain hearing down the road. However, when we talk about serviceable hearing, meaning able to use a hearing aid on that side within 10 years, we do see a gradual decline of hearing related to radiation down the road. About 23% of patients are able to maintain their serviceable hearing. 60% of people do have a little bit of dizziness that is not significantly different from observation arm. The other thing is most patients have very normal facial movement and very normal facial sensation. With radiosurgery, some of the issues, if you've had radiosurgeries with some of the patients may notice a little twitching, what we call synkinesis, a little twitching with your face, or abnormal facial sensation, which is with a completely different nerve, but a little bit pain, numbness, tingling may happen with the radiosurgery. Hopefully those are not very bothersome. And the last treatment option is microsurgery. When you talk about surgical options, and go sort of into a completely different world, the intent is to remove the tumor. With removal of the tumor, there are three different approaches. You may hear about translabyrinthine approach, middle fossa approach, or the retrosigmoid approach. The important key difference is that translabyrinthine actually goes through the hearing organ, so there is no hearing preservation. We usually only offer that approach to patients who have relatively large tumors and no hearing left. And middle fossa and retrosigmoid approaches have variable hearing preservation outcomes, and middle fossa is usually reserved for patients who have relatively small tumor, and retrosigmoid obviously can be used for patients with variable size and variable hearing at presentation. With hearing, obviously with surgery, we're talking about retrosigmoid or facial or middle fossa approach. The hearing, serviceable hearing, meaning that you're still able to use a hearing aid on that ear at 5 years on average is about 35 to 49%. That decreases significantly the larger the tumor is, the harder it is to preserve the hearing. With the surgery, dizziness often gets worse after surgery, but usually people recover. This is because you remove the tumor, allow the brain to compensate for the lack of the balance nerve on that side. And most patients maintain a relatively good facial outcome with surgery. The larger the tumor, the harder it is to preserve that facial nerve function. So this is just a image of the MRI result before and after surgery. This is a medium-sized tumor. You can see with the surgery, obviously the goal is to remove the tumor completely, but the modern technology and the modern understanding of the tumor is that since it's benign, most surgeons will advocate leaving a sliver of tumor behind in order to protect your hearing and facial nerve function. So you may hear that talk about when you go through counseling for acoustic neuroma. And the last but not least, I would just like to emphasize the overall quality of life. And now as physician, we do understand, having seen many of those patients being treated, that the diagnosis, giving you the diagnosis of a vestibular schwannoma or acoustic is actually the most important event that impact your quality of life. The treatment options, no matter what you choose, the quality of life is relatively comparable. So it's really important for the individuals to choose the treatment options that is based on your symptoms and based on your lifestyle. So that is an important finding that we know from the quality of life surveys. And what to do, even no matter what treatment option you choose, you can get help for your hearing, balance, and dizzy functions. Hearing loss, hearing aid, traditional hearing aids is very helpful if you have serviceable hearing. Other options are hearing aids, that talk from one side to the other side. Those are called cross or bi-cross hearing aids, that even if you don't have serviceable hearing on that one side with the acoustic neuroma, you can utilize the hearing from the other side to improve your speech understanding, especially in background noises like, at family gatherings, at work, with a crowd. And there are other hearing technologies like bone anchor hearing implant or cochlear implant. There's a more sort of more involved technologies to help the hearing. That I mentioned those only to say that if hearing becomes a significant issue, definitely get help out there. And dizziness, in terms of dizziness, vestibular therapy, a specialized physical therapist who specializes in vestibular functions is very important to help you overcome, especially patients who have debilitating vertigo. It is very important to help you overcome the dizziness. And patients who have elected to observe or radiosurgery, intratympanic gentamicin, which is injection of a antibiotic into the middle ear space to obliterate the balance function on that one side, can actually become helpful in terms of helping you getting over the debilitating vertigo or debilitating imbalance. And for facial movement, some patients may experience facial transient, so meaning temporary facial paralysis or long-term facial paralysis. There are static versus dynamic procedures to help the facial symmetry, to help with the synkinesis, which is the twitching, or to help with your daily sort of functions like eating, smiling, keeping your eyes closed. So definitely consider seeking help. We have very good facial plastic surgeons out there to help with those. So in summary, this is a very short but hopefully informational session for you, that most of the time we try to manage sporadic vestibular schwannomas with the focus to improve or maintain your quality of life, quality of care. In each individual patient, we try to individualize their treatment plan based on your symptoms and the hearing imbalance and facial functions at baseline. So that's just my 2 cents. Here is some more websites. If you need more information, I'm happy to take any questions right now.
Anybody have questions?